By the end of this video, you will have a thorough understanding about the risk factors, signs and symptoms, the pathophysiology, and how to diagnose and treat preeclampsia and its complications. Let's take Mrs. Jane for a case discussion. You can pause the video if you want to read the case notes in detail. Mrs. Jane is a 40-year-old teacher. She came to the hospital antenatal clinic for the first time at 11 weeks of pregnancy, which at the time her blood pressure was 120/80 mercury millimeters and her urine analysis was normal. Her BMI was noted as 35. Her first pregnancy, which was 10 years ago, was complicated with preeclampsia. She also has a family history of preeclampsia in her mother and her sister. She also had certain pre-existing medical conditions such as diabetes and renal disease. However, her pregnancy was uneventful until 37 weeks, where a community midwife noted Mrs. Jane's blood pressure has risen to 150/100 mercury millimeters and there was protein in her urine. She was admitted to the emergency department, which by the time her blood pressure was 160/110 mercury millimeters and even more protein in urine. By this time, she was complaining of having some visual disturbances, nausea and vomiting, upper abdominal pain, and a frontal headache. It was noted she had edema of her face and hands and hyperreflexia as well. The fetal heart rate, however, was normal. So this would be the most unfortunate case of preeclampsia because she has almost all the risk factors and symptoms associated with it. And before we go into further details, let's get the definition of preeclampsia sorted. Preeclampsia is defined as hypertension of at least 140/90 mercury millimeters recorded on at least 2 separate occasions and at least 4 hours apart, together with urine protein level of at least 300 milligrams in 24 hours, which occurs after the 20th week of pregnancy in a previously non-hypertensive woman. And it should completely resolve by 6 weeks after delivery. An interesting side note regarding the risk factors is that preeclampsia is more common in first-time mothers because the mother is exposed to the fetal products, including the paternal genome, during the first delivery, which protects her subsequent pregnancies. However, this protective effect seems to be lost if a mother has a child with a new partner. Also worth noting in family history, there is threefold increase in first-degree relatives, including parents, siblings, and children. Now, let's understand the pathophysiology behind preeclampsia quickly. Development of preeclampsia is a two-stage process. In the first stage, the genetic predisposition in these people initiates an abnormal immunological response. In normal pregnancy, trophoblasts invade spiral arteries and it's supposed to decrease the resistance of these vessels so that blood can easily flow into the placenta. But in these patients, the invasion of trophoblasts is deficient and patchy, which leads to spiral arteries retaining their muscular walls, as you can see in this picture. This causes increased resistance in the vessels which carry blood to the placenta, thus causing a hypoperfused placenta, which brings us to the beginning of the second stage. This hypoperfused placenta undergoes oxidative stress, which then releases secondary circulating mediators who are responsible for the endothelial dysfunction, vasospasms, and the activation of the coagulation system. These are the processes that bring about the clinical manifestations of this disease. Which brings us to the next topic, the clinical manifestations. So how does all these changes affect the mother and the fetus? Well, the main concern regarding the fetus is intrauterine growth restriction, or IUGR, due to the obvious reason of hypoperfused placenta. It can also cause placental abruptions and in severe cases, intrauterine death or a stillbirth. But in the mother's case, it's a bit more complicated in the sense it affects multiple organs and organ systems, hence considered as a multi-system disorder. First, in the cardiovascular system, there is marked peripheral vasoconstriction leading to hypertension in contrast to vasodilation and decreased blood pressure in normal pregnancy. Also, due to the increased blood pressure and loss of endothelial integrity, the blood vessels increase in permeability, causing generalized edema. Worst complication here being heart failure and pulmonary edema. In the renal system, there is impaired glomerular filtration and selective loss of proteins such as albumins, leading to proteinuria. This in turn causes a reduction in plasma oncotic pressure, which exacerbates the edema. Worst case scenario being renal failure. In the hematological system, endothelial damage leads to platelet additions to the damaged areas. This is also associated with decreased platelet counts. Here, the patient could develop stroke or other bleeding problems. In the hepatic system, it causes increased liver enzymes. If also associated with hemolysis and decreased platelet count, we call it HELP syndrome, abbreviated for hemolysis, elevated liver enzymes, low platelet, and this is how we diagnose each of the three criteria. Moving on to the neurological system, cerebral vasospasms and cerebral edema can lead to convulsions, in which case the condition is called eclampsia, which is considered as an obstetric emergency. Similarly, vasoconstrictions in the retina can lead to visual disturbances or even blindness. Need not to mention, these complications left untreated can lead to maternal death. Now that we have an idea of what exactly is happening inside the body of these patients, let's find out how to effectively look out for these symptoms and complications. Diagnosis of preeclampsia usually requires admission to the hospital, since the majority of these patients are asymptomatic or merely complain of general flu-like symptoms. Investigations are carried out to diagnose and to monitor complications of preeclampsia. For diagnosis, we use blood pressure readings and urine protein levels, which we already discussed during the definition. When monitoring complications, we have to monitor both the mother and the fetus. In the mother, we use full blood count report with emphasis on falling platelet count and increasing hematocrit. If the platelet counts are reducing, we have to carry out additional clotting studies. We take serum renal profile including uric acid levels, serum liver profile for elevated liver enzymes. To monitor the fetal well-being, a detailed ultrasound scan can be done together with CTG or cardiotocogram monitoring to record the fetal heartbeat. Now that we know how to identify this condition and its complications, let's talk about how it can be managed. The definitive treatment for preeclampsia is to end the pregnancy by delivery, which, as you probably imagined, could be a problem in early pregnancy. Therefore, a first step is to always admit the patient to the hospital, because for delivery we have to first assess the maternal and fetal conditions. Then, the first thing we try to manage is the blood pressure. The National Institute for Health and Care Excellence Guidelines, or the NICE guidelines, suggest oral labetalol as the first-line drug to be used in moderate and severe hypertension. Alternatively, nifedipine and methyldopa can be used after considering each of their side effects to the patient and the fetus. In severe acute cases of hypertension, intravenous hydralazine or labetalol or sublingual nifedipine could be used, bearing in mind blood pressure should be closely monitored since they can cause a sudden drop in the blood pressure. And after trying to control the blood pressure, the mother and the fetus is assessed and we can expect several outcomes. One is both the mother and the fetus are stable, in which case the pregnancy can be carried out till the baby develops complete lung maturity and then delivered. Another case is when the mother is now stable with normal blood pressure but the fetus shows severe IUGR with abnormal Doppler ultrasound, in which case a course of intramuscular dexamethasone or betamethasone of choice is given to the mother to speed up the lung maturity of the preterm fetus, and then delivery is considered. Another unfortunate outcome is unstable mother despite the above blood pressure management, in which case the baby has to be delivered urgently at any week of pregnancy. Another possible outcome is that mother is in impending state of eclampsia, that is about to get a convulsion, in which case intramuscular or intravenous magnesium sulfate is given to temporarily prevent the convulsions, and then a mode of delivery is decided. And finally, if a patient do go into eclampsia and develop convulsions, it could be considered as an obstetric emergency and treated as such. The ABC approach is followed with airway clearance by turning the patient into left lateral position and sucking out secretions. B. Breathing supported by giving oxygen. C. Circulation, taken care of by putting 2 large cannulae and sending a blood sample for cross-matching. Then immediately, magnesium sulfate is given and urgent delivery is carried out once the patient is stable. To wrap things up, a few pointers on postnatal care. The antihypertensive drugs are continued, and the dosage can be reduced once the blood pressure reaches 130 or 80. If blood pressure does not normalize by 6 weeks after delivery, then the patient needs to follow up with a physician. Please leave a like and subscribe if you like this video, and let me know in the comments below which topic you want to discuss over your next cup of coffee.